Hello everyone, it's Dr. Locklear and we're continuing with Module 13, Concept Mobility. And today we're going to be talking about osteoarthritis, which is Exemplar 13.E. And so as we look at osteoarthritis, this is a very debilitating um, and painful disease process. These patients really suffer with brittle bones and a lot of constant pain. So what are our outcomes? We're going to look at the pathophysiology of osteoarthritis and what causes this and what is the pathway of how it occurs. Again, the etiology, what are the causes? Can it be prevented? Looking at the risk factors, identify the clinical manifestations. How does it manifest itself? How do you know this is osteoporosis? We want to look at the diagnostic tests and therapies to help us identify OA, and then how do we collaborate to provide the best possible care for a patient with OA. We want to look at considerations for care of patients across the lifespan. So, is it different for this age or this age? And you usually see this in older adults. And we want to apply the nursing process in providing culturally competent care to individuals across the lifespan and consider their needs as how they see what they need as well. We want to always include our patients and families or caregivers or support persons in the care. So let's get started. So what is our overview? So osteoarthritis is the most common form of arthritis. It affects about 50% of the world's population, usually over age 65, excuse me. It develops as wear and tear. So, as we age, our body starts to wear out, constant moving of our joints, the bones against each other. And then if you're very athletic or you love to exercise, that puts more pressure on your joints as well. So causes bones to rub bone on bone. So you may hear that crepitus I was talking about, that cracking sound, because you have a breakdown of the cartilage, and the cartilage is like the sponge in between your joints that keeps them from rubbing on each other, and it helps them slide back and forth. And it does start to wear as we get older. So when you have knee replacements, a lot of times they'll go in and replace that cartilage and put in a prosthetic device. Most common cause of disability in adults. It's very debilitating. It's very painful. And as the pain progresses and the bone gets more weak, they lose their ability to perform their ADLs and care for themselves. It can affect any joint, but usually the hands, knees, and hips. So what is our patho? In healthy joints, you have articular cartilage. It covers the ends of the bones. And this coverage of this cartilage helps our bones glide back and forth, no friction. And it absorbs the shock. Every time you walk, it's a shock to your knees and your hips. But as we start to age, and unfortunately, things start to change as we get older. Things start to wear out and break down. Think about driving a car for 10 years. Eventually it just wears out. And so it wears away. Think about brake shoes on a car. Every 3 or 4 years, that constant hitting those brakes rubs it down low, and you got to have new brakes. So it allows the bone to rub on bone, and that is very painful, and it limits movement as well. Particles break off the joint and irritate the synovial fluid. So once you've got this irritation, then you're going to have some pain and stiffness and inflammation and swelling. And a lot of times the fluid will build up in the knee, and they'll have to go in there with a needle aspiration and get it out. The changes are slow to develop, and so the joint no longer moves slowly. And again, like I said, it prevents mobility problems. It involves weight-bearing joints of the hips and knees and your hands, the big toes, because think about when you walk, your big toe is one of the digits in your foot that helps balance you. So you're constantly putting pressure on your big toe as you walk. And the cervical and lumbar spine, because we know even with just normal aging, our cervical, and we lose inches. and as this wears and tears away. So what causes OA? There's no identifiable cause, but it can be mechanical and molecular factors. So as an individual ages, the cartilage, like I said, breaks down, and sometimes it's just normal wear and tear. It may affect one or two joints. It may affect equal to or greater than three joints. It can be from an injury or congenital situations, metabolic, endocrine, or neuropathic, or other medical causes. And these are your secondary causes. Just like I said, with fractures, some medications prevent us from absorbing phosphorus and calcium, and arthritis can also be genetic, and that's where the endocrine and metabolic comes in. It can be a genetic disorder that you have that well, not RA, rheumatoid arthritis is different, but with arthritis, you can have that component that makes you more susceptible, and so there's nothing we can do about the genetics. Risk factors. So what makes us at risk? Rarely occurs under the age of 40. At least 80% are over age 55 and or older. 60% of people with OA are women, because we bear more weight in our hips and knees, where men bear more weight up in their upper trunk area. But men, have a tendency to be more athletic, than women. Also, with women, when we go through menopause, we lose the ability, as our hormones decline, to absorb, calcium and phosphorus and vitamin D in our bones. Obesity, because just of the weight carries, puts pressure on your bones. And then malformed joints, you may have a congenital defect, diabetes, hypothyroidism, gout, and Paget's disease. And Paget's disease is a bone disease as well. And then again, sports injuries and accidents. Repetitive movement. People who do jobs that they're constantly moving that body part, like I type a lot, so sometimes I can tell my carpal tunnel flares up. Same thing with this. So prevention. So how do we prevent? Ideal body weight. Keep your body weight within your ideal body weight. Participate in exercise programs. Remember, inactivity weakens our bones and our muscles. Use good posture and proper body mechanics. Avoid repetitive stress. It's okay to exercise, but if you're exercising to the point that it's causing you pain, then you're over exercising. And seek treatment immediately if you're having this severe pain or you do have injury. So what do we see with OA? You're going to see multiple things. Look on page 947, and it gives you the clinical manifestation and therapies of OA, and we'll go over this in class. Knee, hip, shoulder, spine, elbow, and ankle. And it gives you the signs that you will see, and then things that can be done to treat it. So make sure you read over that, and we will look at that again, okay? So it begins with mild symptoms, and it progressively worsens. It can be a slow process, and happen, between age 40 and on. Your symptoms vary depend on the joints that affected. So, depending on if you have a lot of stress on your knees, you may see it more in the knee area than in your arm or your hand. Joint pain is worsened by activity, and it's relieved by rest. You have pain, stiffness, and you have stiffness that's associated with prolonged inactivity. So like if you get up in the morning, you just can't even hardly move, or a long car ride. Truck drivers deal with this a lot. It's tender to touch at the joint site. The swelling's related to the excess fluid, and you can see the swelling, and the skin will around that area will get shiny and taut, and it may feel warm as the fluid builds up. Crepitus, that grating sound, bone spurs, and decreased range of motion because you're in pain and it hurts. Clinical manifestations, again, joint pain, degeneration, stiffness, unsteady gait. You may not be able to walk or perform your ADLs. You may lose time from work, and you start to feeling you're losing your independence. So now you're dealing with some psychosocial issues as well. Collaboration. So who do we work with to help these people with OA? Again, nurses and our healthcare providers, a rheumatologist, somebody that deals specifically in arthritis and pain management. OT and PT to help, get that joint moving again. There's no cure, but, surgery may be the only thing that can help replace that lost cartilage there as well. Diagnostic tests, x-rays, MRI, ultrasounds, and joint fluid analysis. And so they'll go with a needle aspiration and pull out the fluid, and it makes it feel a lot better, but they're assessing to see if there's infection in it as well, which can lead to osteomyelitis. Blood tests to rule out other causes to see if it's rheumatoid arthritis or some other type of disease like cancer. Surgery. These are different types of surgeries that you can go through. These are listed on page 949 for you. And so the different surgeries is arthroscopy, and this is debridement. So they go in and kind of clean out the area that's affected. Joint irrigation, and you may see this with arthroscopy as well, and they'll put fluid in to help flush it out or whatever's in there. Small amount of bone removed, metal replacement is fitted over the end of the bone, so some type of prosthetic device. And then an osteotomy, and this is surgical removal of a wedge of a bone above or below the joint. You realign the joint and shift the weight away from the damaged area. And again, these are listed for you on page 948 and 949. Joint fusion. This is permanent fusion of two or more bones at a joint using pins, plates, or screws. Bone graft may be used to help stimulate new growth, new tissue there. And it's used for badly damaged smaller joints, such as in your wrist and so forth. Arthroplasty, this is your total joint replacement. So they're going to go in and actually replace it and give you a prosthetic joint. And one of the risk factors is infection and blood clots. Pharmacological therapy, and this is listed on page 949, over-the-counter and prescription medications. Acetaminophen is the first-line therapy. It can produce liver toxicity in some patients, and there is a safety alert on page 949 that talks about acetaminophen and the safety alert. The warning must include the information that exceeding a dose of 4,000 milligrams a day may result in liver damage. So we definitely need to educate our patients about limiting the number of pills that they take. Your NSAIDs, ibuprofen, naproxen, your cyclooxygenase, your COX-2 inhibitors, and again, opioids. And make sure you're looking for signs of, is the patient becoming addicted, constipation, and then for your ibuprofen and naproxen, does this need to be given with medicines, because these are very irritating to the stomach. And then there's some other ones listed there for you. Cortisone injections, this helps reduce the inflammation, and so you may not have to have surgery for a while. Because OA is progressive, early treatment is very necessary to help improve your outcomes. Non-pharmacological therapies include heat and cold, assistive technology, weight reduction, getting that weight under control. Weight really puts a lot of pressure on your bones. Sleep, sleep in a comfortable position, rest the joint, exercise, education, and coping strategies. Your complementary therapies, acupuncture. I've always wanted to try acupuncture to see if it would help with my sinus headaches. I don't know anybody that does that, so if you do, let me know. Nothing beats a good old massage. Tai Chi and yoga are great. Tai Chi is very low impact. I took a class in Tai Chi one time. I loved it. And then just other different herbal remedies and therapies. Some of these are under investigation. I skipped the slide. I did not. Okay. All right. Look at your diagnoses. These are on page 952: pain, mobility, sedentary lifestyle, and then your planning. And it says, the patient will verbalize understanding of the indications of the medications, the Tylenol, acetaminophen. Can they talk to you about that? They can talk to you about the exercise program and performing a dressing. If they have a dressing on the area where any surgery was done. And then nursing interventions focus on reducing pain, maintaining mobility and function, teaching them how to use their assisted devices such as a walker, wheelchair, cane, and there is ways to do that. With a walker, you have the 2-point gait and the 3-point gait. I'll be glad to talk to you about that. You should have had that in fundamentals. And encouraging proper diet and losing weight. Again, assessment: how do they move? Assess signs of pain, their symptoms, ability to perform their ADLs, and then your physical exam, their weight, range of motion, deformities, and so forth. Here's your nursing diagnosis. So I didn't miss a slide. It was further down. And then there's your planning. And then again, implementation. And we just talked about that on the previous slide. Again, range of motion, mobility assessment, the exercises, medications, PT and OP. Obesity, getting that weight under control. So you may have to pull in a dietitian. Okay, they may be part of the interdisciplinary team. And then here's your expected outcomes. Of course, being able to have autonomy and pain-free if at all possible.